Okay, good morning, dear colleagues. It's a pleasure for me to co-chair this session with Professor Nora Terro, who is replacing Professor Mario Ricchetto. Professor Ricchetto had an emergent situation of the last day, so he couldn't be with us. He will be also replaced for his lecture by Dr. Maurizio Brunetto. So Dr. Brunetto will give two talks in a row. I think we'll have very interesting topics. We continue, of course, with hepatitis B, and we start with quantitative HBs antigen, when and how to use it. This first presentation will be officially, as in the program, given by Dr. Maurizio Brunetto, who has been working with quantitative HBs antigen since decades, since many years before this test has become relatively well known in most of the hepatologies. So, Dr. Brunetto.
Thank you, George, Nora. So it's a pleasure to be here. I want to thank Professor Marcelin for the invitation and for the possibility to talk of an S antigen. Indeed, my disclosure, the clinical interest on S antigen quantification started about 10 years ago when these two papers were published on the same issue of hepatology, showing that S antigen quantification could be useful in tailoring PEG interferon treatment. In fact, in one of the two studies, it was shown that S antigen declined in interferon-treated patients, but not in lamivudine-treated patients for 1 year. And in those patients in whom S antigen declined, these patients were those achieving also a virological response in terms of HBV DNA decline. Furthermore, and even more interesting, the S antigen level at the end of therapy or the decline from baseline to the end of therapy were able to identify with a high risk factor the probability to clear S antigen in the following 3 years after the end of therapy. Thus, indeed, S antigen seems a potential tools to better guide interferon treatment. The other paper show, in addition, that in E-negative patients, the kinetics on treatment kinetics of S antigen could be useful to discriminate not only responder from non-responder and SVR, those patients who maintain the response, but also to discriminate SVR from relapser. And we know that during therapy, this is difficult to be done, only monitor HBV DNA. Thus, the possible practical implications were quite important. In the following years, also untreated patients were studied, and it appeared that in the different phase of in HBV infection, the level of S antigen were different, higher in the so-called immunotolerance. Now we define E-positive infection, the lowest in the E-negative infection when the immunocontrol has been achieved, thus lower level of S antigen in combination with very low level of HBV DNA were shown to be able at the single point evaluation to identify with high accuracy inactive carrier in the E-negative phase of the infection. This mainly in genotype D, but also in genotype B and C, it was shown that having such profile, low level of DNA and S antigen combined, was associated with a better outcome in terms of risk of hepatitis reactivation, of progression of disease, and hepatocellular carcinoma development. Thus, everything is done. We can use S antigen in clinical practice, and everything is easy. This is not the case because even if we are using the viral markers, not only as antigen, but also E and HBV DNA as a surrogate marker of the interplay between the virus and the host, we have to consider that all these markers are viral markers, and therefore they may be influenced by constitutive feature of the virus or of the viral infection. And as far as this is concerned, S antigen serum level may be influenced by the HBV genotype, by the variability of the viral quasi-species in the pre-SS region, and also by the production from integrated segment or portion of the HBV DNA in the host genome. And indeed, in vitro study show that the extracellular production of HBV DNA and S antigen were not parallel, but different. And this, in addition, this varies according to the genotype. The highest secretion level of S antigen being observed in genotype A, the lowest in genotype D, at least in this experiment. And in patients, in the patient population, again, higher level in genotype A infected patients in the E negative population, and lower level in genotype B and C. Thus, indeed, even in untreated patients, the genotype influences the S antigen level, and this has to be considered when we are using it in clinical practice. In addition, when we studied the on-treatment kinetics of S antigen according to the genotype in E negative patients, again, we observed that the kinetics were different, not only between responder and non-responder, but this varies according to the genotype, and particularly, for instance, in genotype C, the difference between responder and non-responder was minimal, I would say absent, whereas in genotype A, the decline was really dramatic, but started after the 3rd month of therapy, whereas in genotype B was, again, very important, but very earlier, already in the first 12 weeks of therapy. So some difference according to the genotype, where genotype D had even a slightly increase of S antigen during the early phase of interferon treatment. And again, this has major implication in the use in clinical practice. What about the regulation of S production and the viral quasi-species? Well, various studies show as pre-SS mutant may be associated with significantly lower level of S antigen in clinical practice. And however, this I think is an issue that we should further analyze and evaluate, because recently we studied 260 E-negative carrier in the different phase of the E-negative phase, some without evidence of disease and with low level of replication, below 2,000 or 20,000, or with chronic hepatitis, without or with cirrhosis. As you can see, there is a difference in the level of S antigen, the lowest being observed in inactive carrier, E-negative carriers, and whereas among those with disease, liver disease, cirrhotic show lower level of S antigen. When we analyze the variability of the circulating viral quasi-species, the presence of a mutation in the pre-S, S1, 2, and S region increases with the presence of disease, and was the highest being observed in cirrhotic patients. However, when we compare S antigen level in patients with mutation or without mutation, as you can see, among particularly patients with disease, the levels were comparable. So apparently, a circulating quasi-species with variants was not able to influence the level of S antigen, suggesting that in these cases, S level could be produced by different sources, eventually by integrated DNA. And here we are considering E-negative patients. In fact, the problem of HBV integration has become more and more relevant and better understood in the recent years, I would say, thanks to the study to develop new drugs, because this study show that particularly in the E-negative phase of the infection, for instance, in the animal model, a significant proportion of S antigen seems to be produced from integrated HBV DNA sequences. More than 90% of mRNA are deriving from integrated DNA in this animal model. Thus, we have to consider this aspect when we are facing with the evaluation of quantitative S antigen in our patient, particularly when the patient, for instance, maintain a high level of S antigen in spite of a low level of replication, or eventually when we are analyzing the kinetics of S antigen decline under antiviral therapy. Because, for instance, when using NUCs, we may have different kinetics according to the extent of integration in the different patients, because it seems from this experiment that not all animals had similar contribution from integration, from integrated DNA in the S production. And these data, of course, are in agreement with very preliminary studies showing that there was a nice correlation between cccDNA and S antigen level in E-positive patients, but not in E-negative patients. So now we start to understand what some years ago was not so clear. From all these data, what we can conclude from the use in clinical practice? Well, in the case of untreated patients, very high and stable S antigen level above or around 5 log international unit in combination with a high and stable level of HBV DNA are the hallmark of E-positive infection phase. Thus, it's useful to identify those carriers in the E phase without major disease activity in their liver. On the contrary, in the E-negative phase, the lower the best, what I can say. If you have low level of DNA and low level of S antigen, this is a good situation because you are in the control phase, in the inactive phase. But if you have low level of S antigen with high level of replication, this can mean that you have a long-lasting immunoclearance phase with the progressive liver disease. And therefore, this could be a worst point in terms of prognosis. However, we have to consider clearly that S antigen serum level can contribute to better define and characterize the virologic phase of the infection, but they will not provide direct information on liver disease. To know the extent of liver disease, we have to rely on other assays like fibroscan or liver biopsy, in some cases ultrasound. So other parameters are telling us about the severity and the extent of the liver disease. And what about quantitative antigen and interferon? We already talked about the possibility to identify a patient with a high probability of clearance according to the value at the end of the treatment. Probably also different threshold according to the genotype, at least in the E-negative patient, may be useful to identify always at the end of therapy those patients who will maintain the virological response in terms of low level of viremia after treatment discontinuation. But several studies show as S antigen can indeed help to identify early on treatment patients who will not respond to interferon, thus allowing to stop therapy very early. In E-positive patients, we have to use, if we want to identify non-responder as early as week 12, different profile level according to the genotype, whereas at week 24, having S antigen level above 20,000, identify indeed non-responder to interferon. In the E-negative patient, we have to combine S antigen with HBV DNA to identify non-responder. This algorithm is particularly true and consistently prove being useful in the genotype D infected patient, whereas in genotype A, we may have some problem, particularly because of different kinetics in S decline, as I showed earlier. But what about NUCs? Well, the problem is that, as all we know, the S antigen decline very slowly, in a very slow way during NUCs therapy, and some studies suggest that many decades of treatment would be required to clear S antigen. And so this is the worst part of our clinical activity, and already we discussed this earlier this morning. But there are some studies suggesting that at least in genotype B and C, level of S antigen below 200 international unit in negative patient could predict a sustained response after lamivudine discontinuation. And a recent systematic review where at the end 11 papers were analyzed to study the correlation between S antigen level at the time of NUC discontinuation and the outcome of the infection after NUC discontinuation show that having level in below 100 international unit, and I think also George recently at the ESLD showed some data on this point, that having level below 100 international units is indeed associated with a lower probability of relapse after NUC's discontinuation. The range is from 9 to 19%, whereas having higher level is associated with a higher risk of relapse. In the E-negative patients, indeed, having level below 100 is associated with a low probability of relapse, even quite low for those patients who have below 300 international units. Thus, these are interesting and promising data that need, however, to be validated in prospective studies. So, in conclusion, quantitative tests provide additional and complementary information to that of viral replication markers. Its level may be influenced by constitutive feature of the virus and of the viral infection. Therefore, the results need to be interpreted according to the clinical setting. And quantitative S antigen is a major diagnostic tool for the management of chronic hepatitis B patients. I thank you for your attention.
Oh, thank you very much. That was very comprehensive and so clinically practical as well.
Yes,
that's terrific.
I tried
Thank
to
you.
make very practical from the clinical
Excellent,
point of view.
excellent. Do you need a breather before you do your next talk?
I can.
So we're going to welcome you back to the stage, really to stay on topic and now deal with Delta.
Yeah.
And we're excited to see what is new in terms of therapeutics for this virus.
So could you help me? Thank you. So I'm sorry for you, because of course having a talk given by Mario Rizzetto would be more important. It's okay, the next one. No, it's the next one. Is this on that, yeah? Because of course of his experience on the field, long-lasting from the very early beginning. In any case, I will present his slides, and so I will try to go through his thinking, just giving some personal observation every now and then. So let's start. What's new on Delta treatment? Well, starting from the very beginning again, we have to remember that Delta is a defective virus that requires HBV helper function, that is mainly a function due to the fact that an helper function due to the fact that HBV coat the ribonucleoprotein by its surface antigen, and this is required to enter the hepatocytes and also to be secreted. The new drugs that are under investigation for Delta are indeed, at least in part, drugs that are acting on the on S antigen, on a specific and major step of the entry and of the morphogenesis of the virus. And we will discuss about the inhibition of the export of HDV virion by NAPS, particularly Rep2139, that it presumed to interfere with the synthesis of subviral S antigen particle. We discussed about lonafernib, that is drugs that inhibit the farnerization, that is an important step in the morphogenesis of the virus of Delta, and is important because also of favoring the interaction between the Delta antigen and the S antigen, so is acting on a specific and very important step of the morphogenesis, but not of the replication of Delta, because Delta is replicating without the need of the help of HBV, but using cellular enzymes. Finally, we will talk about, or better, we will also discuss about the block of HDV entry into the hepatocytes by the synthetic peptide Mirko, that we already heard about these new drugs earlier. At present, all these drugs are mainly under evaluation in clinical trial where they are used in combination with interferon, PEG interferon. And we know that PEG interferon is at present the drug we are using with our Delta patients, that interferon is able to control the disease at the end of treatment in 20-25% of the patient. The problem is that in most of them we will have a relapse during the post-treatment follow-up. That is not, is a suboptimal treatment. What about the Rep 2139? Actually, we are considering mainly the data that had been presented on the paper on Lancet in 2017, This paper is very interesting and very promising. The major limitation is the number of cases that is quite small, but it's important to observe as we had a major action of the drug on the decline of S antigen in the majority of the patients, and in some of them, I would say in a good proportion of them, a very dramatic decline of S antigen that was combined with a dramatic decline of HDV RNA, more than 5 log, with 92% of the patients having HDV RNA undetectable at the end of therapy. And as you can see here, this happens also in those patients without a major S antigen response. So in any case, we had a DNA decline in the vast majority of the treated patients, which are the problem that still we have and the question we are that we should try to better understand and answer, are mainly the problem of the mechanism of action of this drug. We know that NAPs are quite different action, antiviral action, and possibly different NAPs may act differently in the different viruses exploiting their antiviral activity. At present, we have not final evidences supporting consistently that NAPS is blocking the release of S antigen and subviral HPV particle. Thus, we need additional study better explaining the mechanism of action. We know from recent study that some NAPs may also inhibit HDV entry, and this is very interesting as a combination of action on the viral biological cycle. We have some worry about potential theoretical risk. Always we are discussing about the risk of S accumulation in the cytoplasm, the risk of hepatocellular carcinoma, because we know that in the natural history of chronic hepatitis B, having storage S antigen in the cytoplasm may be associated with a higher risk of ACC, but at present, no evidence of major toxicity has been available. And other possibility could be the interaction of these NAPs with proteins or lipoprotein, giving the denaturation or alteration of their activity. But again, these are theoretical risks. We don't have evidence at present of this problematic aspect. Of course, it would be better to have an administration less demanding, and we know, as far as I know, there are studies to make easier the administration of the drug. And finally, the problem of ALT elevation we discussed already today. Here are the data on HBV in negative patients, and ALT flare occur in 90% of the patients, and in any case were mainly associated with the control of the disease. That indeed seems that these flares are flares that are part of the mechanism that bring to the control of the infection. However, as clinician, we are always worried about the flare because, of course, we have to be cautious because of the liver of our patient. We may cure the hepatitis, but losing the liver, and this could be, in extreme situation, a major risk. But going back to the use of Rep 2139 in Delta patients, it is interesting to know the fact that we had two populations. A population with a flare, and this occurring usually early after the addition of interferon to Rep, and this occurred mainly in those patients who had a more dramatic decline of S antigen in the early pre-treatment with the Rep monotherapy of S antigen. Whereas these flares were less frequent observed in those patients who maintain higher level of S antigen. And this is, in my opinion, quite interesting because in telling us that we have different patient population who may have different response to the drug. Indeed, those who achieve the flare had, in most of the cases, a profound increase of anti-S and the maintenance of the functional control of HPV. That means that for some reason, we don't know whether due to the immunological response to a different situation of the HBV infection in these specific patients, having a flare was a good event in terms of control of disease. Just another observation. You can see here that, at least in my impression, AST were usually increasing more than ALT. And this suggests that indeed some toxic event could happen, because usually in the typical flare in untreated patients, we observe, also in interferon-treated patients, we observe ALT higher than AST. So this, I think, is an interesting point for further evaluation. Well, we move to lonafarnib. To date, over 120 patients have been treated with this drug in phase 2 clinical trial, mainly aimed to verify the tolerability, the safety, and the efficacy of the drug, and different posology were given to the patients, different combinations were attempted, and particularly it was been shown that the addition of ritonavir, that is inhibitor of the cytochrome that metabolize lonafarnib, is important to obtain higher serum level of the drug with less side effect at the gastrointestinal level, because we know that this patient may have anorexia, nausea, diarrhea, and this is a major problem in terms of clinical management. Thus, having the possibility to obtain a good level of the drug at the serum level without major side effect is a major point. At present, the most promising regimen for long-term use are lonafarnib 15 milligram plus ritonavir given oral, or combination with interferon. Again, some problem with this treatment in terms of potential toxicity. As I told at the beginning of my talk, with lonafarnib, we are not blocking delta replication. Thus, HDV-RNA may accumulate in the hepatocytes. And this could be a problem in terms of toxicity at the cellular level. And this has to be better analyzed and studied in terms of potential toxicity. The other point is the attempt to optimize and to reduce the side effect, and because the patient tend to have a major weight loss in addition to the symptoms. So trying to do this is under consideration the use of lambda interferon that we know is show usually less side effect, and recently has been shown showing antiviral activity in HDV infection. Thus, in the near future, we will have study where lonafarnib will be combined with the interferon, standard interferon, alpha interferon, and also with lambda to see about the antiviral activity and the management of the side effect. In addition, it's interesting to know that in some preliminary data, the combination of all oral treatment, lonafarnib 50 milligram plus ritonavir, was associated with a high rate of response, virological response in terms of HDV-RNA undetectability after 6 months of therapy in patients who started treatment with low level of HDV-RNA. Thus, again, also in the case of lonafarnib, it could be important to have a stratification of the patient, a characterization of the delta patient at baseline before starting the treatment to define the optimal regimen for the different patients. Finally, Mircludex. Well, we already learned that is synthetic N-acetylated PS-derived lipopeptide that inhibits HBV, but also HDV entry by blocking the NTCP receptor. And in the case of delta, blocking the entry of the virus in the hepatocyte, this should favor the proliferation of virus-free hepatocytes target to obtain the elimination of the delta infection. The most recent data were presented by Wademeyer at the SLD last year, in 60 patients, Mircludex was given in monotherapy or in combination with interferon, and a group of patients received PEG-interferon monotherapy for 1 year. And as you can see here, we had the experience was about an important decline of delta RNA, particularly in patients who received the combination with interferon, both 2 milligram or 5 milligram. However, also those who had monotherapy with Mircludex show a decline, 2.8 log at the end of therapy, comparable to that observed, even slightly higher, comparable to the patient who received interferon monotherapy. In terms of ALT, in this case, patients who received the monotherapy with Mircludex show a progressive decline of ALT, more important as compared to patients receiving interferon who maintain some disease activity, as you can see here, the major disease activity being in terms of persistent of ALT elevation was observed in the patient receiving 2 milligram PEG interferon. So, this suggesting that, as we know, interferon is usually associated, at least in part of the patient, with a persistent disease activity or an activation of the immunoelimination we hypothesize disease. The other important point is that in those patients who had a major HDV RNA decline in the serum, this patient also had a decline of delta antigen in the liver. And here is a case, it's suggesting that what we see in the serum is associated with a reduction of the infection in the liver. And this is indeed a major point in terms of control of disease. So, trying to make a synthesis, distinct decrease of the delta RNA was observed also in patients receiving monotherapy, but in this case, the reduction was of a lesser extent. There was a decrease of the ALT, but was better in those patients who didn't receive interferon. No relevant biliary problem, no pruritus, even there was a slight increase in biliary acid, but without symptoms. Overall, no major effect of S antigen, but again, if we look at the different profile of S decline according to the different treatment, we can observe that in some patients receiving interferon in combination with 2 milligram or 5 milligram of Mircludex, again, there was a profound response in S antigen. So again, it appears that my beloved S antigen could help to discriminate subgroup of patients showing different profile of response to the treatment, also in the case of Mircludex. So what's next? Prolonged therapy with the ultimate goal of eradicating the delta infection. For how long? Which are the predictors, the endpoints? Well, we have some problem because of the HBV DNA integration, because producing S antigen could be a source of S to warrant the persistence of S infection and to have a productive S delta infections. This might explain why Mircludex has a major effect on HBV and DNA, but a minor effect of S antigen level. But another major point that has been really recently raised by the group of Mauro D'Andri is that HDV persists during liver regeneration by transmitting HDV RNA to dividing cell even in the absence of HBV co-infection. So the persistence of disease activity, inflammation, and regeneration in the liver could be a way by which delta stay in the liver and spread in the liver. And this may be a reason for the difficulty in clearance the virus. Therefore, we should maintain HDV RNA ALT normal for a long period of time, having a sort of functional control. But again, Wademeyer showed in last year's meeting the response to Mircludex combined to tenofovir. And as you can see here, show a very pronounced decline on delta antigen in a significant proportion of patients, combined with a normalization of ALT in those patients who receive tenofovir with Mircludex at the higher 5 or 10 milligrams. So this is interesting. And indeed, the author suggests that the serum and intrahepatic HDV decline were associated with reduction of ALT and the inflammatory cytokines in the liver, reducing HDV infection. And this could be a way to reduce the spreading of the Delta virus according to the recent data from the Dandri study. To conclude to slide and to say that now what we need is to have also for Delta new biomarkers able to guide therapy, to early identify the response to therapy, and a panel of experts on the field suggests the 2-log drop in HDV RNA early during therapy could be a good parameter to assess the efficacy in clinical trial of the new therapy, and this is very important. Personally, I believe that we should try to better classify and characterize, stratify our patient, at least to know the different virological profile, being able to make an interpretation of the response to the different drugs. I think this is very important because, as Mario suggests, we have to remember that surrogate endpoints that often we use in clinical trial are used to have short endpoints when the clinical outcome is long. But not always these short endpoints, surrogate endpoints, are really a marker of what we would have in terms of benefit on our patients. So we have to be very we have to remember this, being able to correctly combine the need to have biomarkers of response, but knowing that having an efficacy from the virological point of view not necessarily means having a better outcome for our patient, even if we hope that this is the case. Thank you.
Thank you so much, Mauritia, for both talks. Please come and join us here. And we continue with a very sensitive issue. Now, pregnancy is always an issue, concern for not only for the ladies, but also for the man, the couple. So how we treat during pregnancy, Professor Senjin Lee will discuss the topic.
First of all, thank you, George and Nora, and I'd like to thank Patrick, of course, for inviting me to this wonderful conference. It's a great start at the beginning of the year to come to Paris. My brief is to talk about HPV treatment during pregnancy, and this is a sort of a field that we take for granted because we already seem to know a lot about this, and there hasn't been that many new developments in recent years. These are my disclosures. So I'm really going to discuss the talk in two aspects. First of all, the risk to the mother and the risk to the child. And for the mother, the risk during birth, non-hepatitis B-related risk and hepatitis B-related health risks. And for the child, clearly, whether there is a risk to the fetus and transmission, which is really our major concern. So when we look at HPV infection on pregnancy, it does not increase the risk to the fetus, but in acute infection, there is an increased risk of low birth weight and prematurity. For chronic infection, there may be an increase in gestational diabetes, antepartum hemorrhage, and preterm delivery, while those with advanced cirrhosis actually have bigger problems. As we know, it's not usual for patients with advanced cirrhosis to become pregnant, but those who do, they have possible second trimester development of esophageal varices, consequent bleeding, hepatic decompensation, jaundice, and rupture of splenic aneurysms. But this is not very well described because these are not commonly seen. A meta-analysis showed that in the mother, there's a 28% increased risk of preterm labor and a 16% risk of preterm birth. So there clearly hepatitis B infection effects on pregnancy, especially during delivery. And there is an odds ratio of 1.47 of gestational diabetes. While the good news, I guess, for the fetus is that there is no increased risk of fetal abnormalities. Now, there is well known that hepatitis B during pregnancy causes changes in the immune system, and there's belief that there is increased tolerance against hepatitis B during pregnancy, and this may be modulated by the development of E antigen. There is reactivation of the immune system, and most of these are seen after pregnancy. So the hepatitis B flares in pregnancy, this is looking at a number of studies where they looked at the development of flares during and after pregnancy, and we can see that overall there seems to be an increased risk of flares in pregnancy, especially after pregnancy, after delivery, rather than during pregnancy, consistent with the belief that the immune system is sort of suppressed during pregnancy, but after delivery, this leads to increased risk of reactivation. And the odds ratio of flares in pregnancy, after pregnancy, is related to the development of E antigen and the older age. And we can see that there is an increased risk of flares with increasing levels of DNA at baseline. So those who have more than 6 log HBV DNA have more than an increase, 20% risk of hepatitis B flare after delivery. So this is something I think we should be aware of and keep in mind when monitoring our patients. What about HBV transmission? So this is really the major issue we're coming to deal with. So as many speakers have already told us, there's 257 million hepatitis B carriers that's estimated globally. In the East, it's about 60% of this group, and that's believed to be the major cause of perinatal transmission. While in the West, there may be a bigger influence of horizontal transmission through sexual contact, contaminated needles, healthcare workers, and transfusion. It is well known that hepatitis B E antigen can cross the placenta, but not the virus itself. So this leads to the induction of T-cell tolerance, and that disappears after about 24 months of age. And the transplacental maternal antibodies, however, we should note, are not indicators of HBV infection status. The mechanisms of vertical transmission are possible due to the infected embryo, amniocentesis, infected PBMCs, microtransfusion of maternal fetal blood, placental infection, but the most common of this is transplacental leakage during delivery. Now, this leads to, of course, chronic hepatitis B infection if there is transmission, and in the days before vaccination was instituted, the mother-child transmission was highest in those who are E antigen positive. In this original report by Beasley, 85% of E antigen positive mothers transmitted hepatitis B to their child, while only about 31% of those who are E antigen negative. And this decreased with age. In the perinatal stage, it was the highest at 90%. Preschool is about 23%, and the young adult, it reduces to below 5%. Now, this is quite important because E antigen prevalence in females of reproductive age between 20 and 39 is actually quite consistent. So this is the prevalence of E antigen positive status in hepatitis B carriers of women of childbearing age. And you can see in the arrows, whether it's in the Asia-Pacific high-income countries, Western Europe, or in North America, this is around 20 to 30% of mothers. So these are the people who face the greatest risk of transmission to the child. Now, the good news is that the hepatitis B vaccine program has now been in place for more than 25 years, and in this meta-analysis by the WHO, it's led to a global reduction of hepatitis B prevalence by 76% in those vaccinated versus those who are unvaccinated. So a very successful program. So what is the additional advantages of this program? When we look at a country like Taiwan, which was one of the early adopters of hepatitis B vaccination, we can see that the impact of HCC in children aged 6 to 14 years has dramatically reduced from 0.7% down to 0.19% in 207. So this tells us that the early indicators has impact on important outcomes like HCC is in fact coming into play. However, the implementation of these vaccine programs is not ideal. This is a snapshot of the vaccine program in the Asia-Pacific region. You can see certain countries like India and the Philippines, highlighted in orange here, do have a suboptimal infant coverage. Now, India, of course, has improved from 2008, where it was only 10%, to 40%, but is still below par. In Philippines, we still have some way to go. This is the 3-dose hepatitis B vaccine coverage in 2017 reported by the WHO. The global coverage is 84%. Now, you might think, oh, this is something we're really doing quite well. But the 16% coverage failure leads to approximately 5 million new infections per year. So we're really not doing too well at all when we're looking at 84% global coverage. Moreover, I think you may not see it very well here, but actually Eastern Mediterranean and European countries, the European regions, are below the 84% average, and in fact fall in the same band as Africa, God forbid. And here's a snapshot of the European countries who are not doing so well in terms of the vaccine coverage in red here. I won't highlight them, but you can see them clearly. There's quite a few European countries that only have 50% vaccine coverage. And so this is something that we can really do much better in, because without an effective vaccine strategy, this is the only strategy that's leading to hepatitis B elimination today, and without adequate coverage, we're never going to achieve the 2030 WHO goals. Moreover, the hepatitis B birth dose coverage is even poorer, 39% global coverage. As you know, hepatitis B vaccine should be given within 24 hours of birth, but this is really not being achieved, and the biggest culprit, of course, is Africa for obvious reasons. So to summarize this section, HPV vaccination has effectively reduced global transmission rates by 76%. However, global coverage is only 84%, and many regions, including European, Eastern Mediterranean, Africa, are below the global average. And what we need to know now is that vaccination alone is probably not enough. So this is a meta-analysis looking at the vaccine alone compared to placebo, and this is a systematic review telling us that in e-antigen positive patients, this reduced the mother-to-child transmission rate from 71% to 19.8%. So not too bad, but that still leaves around 20% of patients who are still going to have transmission. Surprisingly, e-antigen negative patients, the vaccine was not very effective on its own. Now, when we look at combining the vaccine with HBIG, you can see there's a further reduction with the plasma-derived vaccine from 20% to 10%, and from the recombinant vaccine from 30.9% to 18.9%. So both of them showed approximately a 10% reduction with the combination of HBIG. And overall, the reduction of HBIG on vaccine has reduced it to around 4.3% in this meta-analysis. One of the concerns about the mother-to-child transmission rate is that not all, even with the HBIG and vaccine alone, we can see that we're still getting quite a significant number of cases of transmission, and this seems to be related to the HBV DNA level. In those who are DNA positive, 13% transmission versus DNA negative 4%. And we can see here, if we stratified by the HBV DNA by copies per mil, if you have less than 6 log, it's 2.7%, but it increases to 14% with more than 8 log of virus. And this certainly is the reason why transmission rates are still relatively high today. So the risk factors for mother-to-child transmission, E-positive status, high maternal HPV DNA, and up to 20% vaccine failures in e-antigen positive patients, especially those with high HPV DNA. So the strategies for reducing transmission further in these mothers constitute clearly antiviral therapy. So here becomes a choice of antiviral therapy. You can see that in the right-hand side is category C drugs, where there are no studies or no adequate studies in humans, with the exception of lamivudine here. There is some effect of the drug on the fetus. And in the category B studies, animal studies have not shown any significant abnormalities, and there are clinical studies to support the use of both tenofovir and talbivudine in pregnancy. The guidelines recommend primarily tenofovir, which is a preferred drug. And here is a meta-analysis looking at the reduction of transmission with the addition of antiviral therapy here. You can see that overall, the patients in the control group had an 18% transmission rate. With addition of antiviral therapy, it was reduced to 4.2%, and this effect is consistent whether it's with lamivudine, talbivudine, or tenofovir. All showed a consistent reduction in mother-to-child transmission. The good news also is that this meta-analysis showed that no evidence of congenital malformation and prematurity rates comparing anti-antiviral therapy versus control. So as far as the safety of these drugs are concerned for the fetus, it appears to be well established. Now, surprisingly, there is also evidence in this meta-analysis that cesarean sections is better than vaginal birth to reduce mother-to-child transmission in this meta-analysis. However, I should warn you that even though there's a 38% reduction on mother-to-child transmission in all these babies who receive both HPIC and vaccine, there is considerable heterogeneity, and this did not factor in the use of antiviral therapy. So with the use of antiviral therapy today, I think this probably has been superseded. As far as breastfeeding is concerned, there's no risk to mother-to-child transmission with breastfeeding. You can see it here in this meta-analysis, breastfed babies, 4.9% mother-to-child transmission versus non-breastfed, 4.7%, almost identical. So finally, it comes to the guideline recommendations. And here, the guidelines are fairly consistent. Antenatal testing of HPV is recommended for all. Hepatitis B vaccination at birth, recommended for all. Routine use of HPIC is also recommended for all. Antiviral therapy in the third trimester is also recommended for all. Criteria to start antivirals is relatively consistent. 200,000 IU per mil for ASLD and EASL. EASL have added in quantitative S antigen. I'm not sure there's a lot of data for that. And for APASL is 6 log IU per mil, slightly higher. Choice of antiviral is tenofovir consistently, although in APASL, talbivudine is also accepted. Now, stopping therapy, that's where there's some disagreement. 4 weeks postpartum for ASLD, 12 weeks for EASL, and at delivery for APASL. So this is an algorithm to manage your patients. Pregnant women who are S antigen positive, you should check their liver panel in the first trimester, and you can consider treatment of active disease if they're found to fulfill the guideline requirements at that stage. In the second trimester, if they have HPV DNA levels less than 200,000 copies or 200,000 IU per mil, continue monitoring. If in fact it's greater than 200,000 IU per mil, then you should really start therapy with an antiviral agent, tenofovir, or in some cases talbivudine, and then you can stop therapy after delivery. For safety reasons, you should monitor these patients for hepatitis B flare after stopping therapy. So to conclude, ladies and gentlemen, chronic hepatitis B can lead to increased risk of obstetric complications. Interruption of mother-to-child transmission is the most important method for HBV eradication today. So it's very important that we are able to execute the coverage for hepatitis B effectively. The global coverage is 84% for vaccination, and some regions are falling below this, and I would encourage you that in your countries to improve that coverage rate. Even with optimal prevention, mother-to-child transmission can occur in 18% due to high viral load and e-antigen positive status, and antiviral therapy can reduce this by 74% without any adverse events. Breastfeeding is safe, and stopping antiviral therapy after delivery is recommended, but with adequate monitoring. Thank you for your attention.
Wonderful. Thank you, Sinji. We have some minutes for questions, so feel free to send your questions in either written or via the app. But I'm going to start, if I could. So, Sinji, one of the newer aspects that came out around sort of transmission risk is an amniocentesis. So there was a recent study suggesting that that's a higher rate of transmission in women who underwent amniocentesis, and that usually happens early in pregnancy when most of us are not thinking about using antivirals. So I wanted to get what are you recommending to patients? What's your advice?
I think there is some evidence of increased transmission with amniocentesis. So it's a balance whether it's safe or not safe to start antiviral therapy. I think tenofovir actually has quite a good safety record, even in patients who are pregnant, who received tenofovir before they became pregnant. I think the FDA has quite good data showing it's safe. So I think to reduce mother-to-child transmission, I would err on using tenofovir in patients having amniocentesis.
Yeah, I would do the same. Tarek, please. Can we have the mic on, please?
Congratulations for the excellent lectures. One question for Maurizia. According to endpoints for early developments, for HBS HA quantification, HBS can be produced by the DNA integrated, so it makes it complex. We have now new markers with the RNA. Would you consider a decrease of 1 or 2 log of HBS plus RNA decrease if everything go in the same way? For a decision of go, no go, would you take into consideration a combination of different markers?
In the case of HPV, okay. So I think that for sure the combination of S antigen with the additional new markers, for instance, RNA or eventually also correlated antigen, even if we have some problem with the sensitivity of the assay in terms of correlated antigen, could be useful to guide and to better understand at the single patient level the profile of response. So indeed, the combination of the assay, at least in this phase where we are really trying to understand how the patient are responding to the different drugs, would be very important. The problem with S antigen at present is indeed the fact that having, I don't think all the patients in the same way, a production from the integrated DNA. This make more problematic the understanding of S kinetics, because indeed in some patients the kinetics is influenced by this extra direct viral infection production. So this is a major issue, I think.
Professor Saran.
Thank you. My question is to Professor Senghi Lim. The debate is only on when to start antivirals at 24 weeks or 26 weeks. We just want to draw attention to 2 studies, one of which was published by us, that it is the mother who probably is the cause. It is not the transmission. So there are 2 types of mother, transmitting and non-transmitting. And it is the defect in the mother which during pregnancy permits transmission of a group of mothers to the baby. And this is related to follicular T cells and somewhat transitional B cells. So the question in our mind has been, should we continue or start antiviral in the first trimester rather than in the 3rd trimester? And will that reduce the possible transmission? And this has 2 aspects. There are some mothers who are already on, let's say, tenofovir, and they get pregnant, and we never stop, they continue. And there's another group who we intentionally start at, let's say, 24 weeks and say that the transmission is reduced. So the question remains, can we and should we start antivirals during first trimester where we think the transmission might occur at week 6 or week 8, rather than wait till week 24?
Well, excellent question. Professor Sarin, as usual. I think the meta-analysis shows that with antiviral therapy, you're getting about 4.2% transmission. So the question is, would you reduce this even further? Of course, we'll have to do a clinical study to show that, and I'm sure you're very capable of doing that, so we'll wait to see your results.
Well, I would like to ask Nora, what would you feel? And is it safe to give, and is it okay to give antiviral in the first trimester?
I think the safety data is there. I think Sanjeev already sort of alluded to that. We have a lot of data actually from the HIV literature where tenofovir is given throughout pregnancy and where we have a lot of safety data. So I think the drug is safe. I think it's going to be an enormous task to do a study to show a differential when we already are so successful with third trimester antiviral therapy to show a differential with, antiviral therapy throughout pregnancy. But I think there's some certain circumstances where one does worry, and I think this issue of amniocentesis is one of them, where when you're doing procedures, or if women have a complicated pregnancy, that might be a woman who's at much higher risk, and doing third trimester treatment is not going to help. So your point is well taken, and I'm not sure we'll get the answer, but I think it's an important question to try to address.
These patients might have transplacental leaks.
Yeah,
I mean, it's not
correct,
common,
correct.
but that's probably why that third trimester is still around 4% and not lower.
Correct. Over here, sorry, I can't
Hi,
quite see you.
Moitza Matici, Slovenia. Very brief question regarding prophylaxis in the third trimester of pregnancy and using tenofovir. Does it matter? Is it TAF or TNF?
I don't think any studies have been done with TAF yet, but since the basic ingredients is similar, it should not be a major issue.
I have one quick question on Delta. No, I mean, Delta is really such a challenge for us. Unlike B, where we've got these, we may not have the cure, but we have very successful, easy to tolerate, therapies. Delta, we're desperate. We have nothing really to offer these patients. So I'm wondering in terms of, advancing clinical trials, whether we sort of have a lower bar because in some level we really need some therapeutics to get to market.
Yeah, I completely agree with you, because the problem also is that a significant proportion of Delta patients have advanced cirrhosis. So for instance, in this case, we really need to control the disease in terms of persistence of necroinflammation because of the risk of hepatocellular carcinoma. So having some way, some therapy able to control the disease, even not clearing, would be very important. For this reason, I had the slide on Mircludex and tenofovir, because indeed these data are quite intriguing in terms of possibility to control without, of course, completely cure the infection, but could be a way to treat at least a proportion of patients. Otherwise, it would be important to completely clear the HDV infection, and this can be reached in a proportion of cases, apparently, according to some preliminary data. But we have also to consider the patient in more advanced phases of the disease. In this case, interferon cannot be used.
Right. Agreed.
Could I ask a question to Maurizio about
please.
REP? All the studies with REP that's cleared S antigen require interferon. So is it due to interferon or due to REP?
The problem is that probably when we obtain a decline of S antigen, we are in some way, we need also to have some immunological response. Actually, if we look at the way in which interferon is acting on the immune system, we know that in the early phase it's not directly acting on the adaptive immune response, but on the innate immune response. So it's possible that this boost of the innate immune response induced by the interferon is a cofactor stimulating the final complete immunological response able to control the disease. But possibly in the future we could think about different immunomodulator, probably coacting with the decline of S antigen in these patients.
Peter?
Well, just a remark to the Mircludex or any of these new hepatitis D drugs. I tried hard to get hold of these drugs. I was told they are preparing a compassionate use program in Europe, but where they are charging a 6-digit figure in euros per patient per year. So there is a definite need for support by scientific communities to make it possible, because the company behind Mircludex is a Russian company with very limited funds. I don't know about lonafarnib, but I think it's a similar problem. These companies cannot afford to do large phase 3 trials, so there's definitely need for some support. And the second point I want to make, I'm struck about the increase in bile acids on Mircludex. It's in my patients 20 to 25-fold, but they have no problems. This gives you a new idea about cholestasis.
Yeah, tell us that pruritus is some way due to other factors that are responsible for it. Yeah. You know, the problem is that the problem is that the virus is using S antigen to enter the hepatocyte. So the best way to block delta is to block the entrance of the virus that is on S antigen. So this is the tricky point, that is difficult to target delta with a different inducing a different immune response, because the neutralizing antibodies against HBV. And when we have delta, HBV is there. So the best way is to protect from HBV. The problem is for, of course, as you are raising the question, all the already S-positive patients, but in this case, at present, it's difficult to find a target for the vaccine different from S antigen for delta, because you don't have the delta antigen expressed out in the outer part of the virion. You have S antigen. So this is the different task for immunologists, I think.
And I'll take one last question. Are you, no? No one. Okay, very good. All right, well, I want to close this session. I want to thank our speakers. Amazing job, and also the audience for their questions. Really well done.